Hey guys, Dr. Dustin here, and I'm a double board certified pain management physician. This video is for patients or doctors who want to know how I manage patients with long-term opioid therapy. So I think, the goal for anybody who is in long-term pain management should be to not only reduce their pain and function, but also to reduce their dependence on long-term medication, including opioids. And so that is how I approach this type of patient. Number one, we want to control your pain. That is first and foremost, and we will do anything within our scope of practice to get that done. Of course, along with that will be the maintenance or preservation of function. And then if we can accomplish those goals right there, then we'll take the next step to reduce your dependence on medication, if at all possible. For some patients, that's maybe not so possible or less likely, and so we have to maintain them longer for a longer period on opioid medication. Now, this is a sort of a controversial topic, a hot topic. How is it that doctors can or do, or maybe not so well, maintain somebody on long-term opioid therapy? And I think that the approach should definitely be individualized. The same way I would approach a younger patient may not be the same way I approach an older patient. And that's simply because the younger we are, the more plastic our brain is, the more adaptable it is, and the more likely we are to develop tolerance that results in dose increases and higher risk behaviors. Conversely, the older we get, the more static our brain is, the more set in our ways we are, so to speak. And so I don't see the same level of tolerance developing in those individuals, although it can vary case by case. Now, there's two key words I want to talk about in this case. One is opioid rotation, and the other is dynamic dosing. These are the two big things that I use frequently to manage patients with long-term opioid therapy, both safely and effectively. Before we get into opioid rotation, I like to do something called pharmacogenetic testing. And the earlier on in the care program of my patient, I like to do that because it gives me a lot of information about that patient. Pharmacogenetic testing is basically just a mouth swab, and we send your DNA off to the lab. They send me back a big report with a bunch of different genes and enzymes and all these things, and it tells me how well you metabolize certain drugs, in this case, opioids. Why would I want to know? Well, opioids are metabolized in different ways. For example, hydrocodone by itself is not very active in regards to pain relief. But when it's metabolized through the liver, through certain enzymes, it's converted into a different form that is more active and causes more pain relief. However, if we do the genetic testing and we find that for whatever reason you're lacking those certain enzymes in your liver, then you're likely not able to convert that hydrocodone into its active form. And so if you're taking hydrocodone and you find that it's not very effective, that could be a reason why. Without knowing that information, that can not only cause you to have false information, but also your physician. The idea might be, well, maybe your pain is worse than we thought. Maybe we just need to keep increasing the dose. Next thing you know, you're taking 6 or 8 pills a day and barely getting by. And everybody's judging you for it, right? So we don't want to give you more than we have to give you. We want to give you something that's going to work. And by knowing what your liver and your enzymes are capable of, that's going to be super effective. One example I can think of just to illustrate this further, I had a patient come in. She was maintained on morphine for a long time, several years in fact. She had a very complex medical condition. And unfortunately, this resulted in a lot of pain. Well, her pain management physician retired, and so she was forced to seek alternative care. This new pain management physician was not keen on prescribing morphine, and so switched her to hydrocodone. Well, being the good patient she was, she went along with this plan, but unfortunately resulted in much more pain, pretty much right out of the gate. And this went on actually for 2-3 months with frequent dose increases of that hydrocodone. And she even had to go to the ER because her pain was uncontrolled. So she finally gave up on this physician because she wasn't feeling like she was being heard. And she ended up in my office. I immediately ran a pharmacogenetic study, and it showed that she was lacking the enzyme to metabolize hydrocodone into its active form. And so I switched her back to morphine, which does not require that same conversion. And immediately her pain was relieved, and she was so happy, back to living her normal life. So that is how important the pharmacogenetic testing can be. When it comes to opioid rotation, this is based on the fact that we have multiple opioid receptors in our brain. We have three main categories, at least, that we know about. That would be the mu receptors, the kappa receptors, and the delta receptors. Now, under each category, there's multiple subtypes. Each opioid medication is going to react differently with different subtypes of these opioid receptors. And so you can take, let's say, hydrocodone, and then let's say we switch you to oxycodone or even morphine, for example. It's going to result in a different effect because those medications are going to be targeting different opioid receptors in different concentrations. So by switching one opioid to another, we're able to maintain a certain dose level, but also by increasing the effect of that medicine. So let's say we're sticking around 10 or 15 oral morphine equivalents, which is our exchange rate, right? Per dose, let's say. We can do that between hydrocodone or oxycodone, same dose, but much better effect, let's say, by switching between the two. And you can imagine, the longer you take one particular medication, especially the younger you are, the more likely you are to be used to it, and the less likely it is to be effective at that current dose. So opioid rotation is a very powerful tool that we use to maintain a similar dose over time and maintain that efficacy as well. The next term I'd like to focus on is something called dynamic dosing. Now, dynamic dosing essentially recognizes the fact that pain is not a static experience. It's not a static condition. It waxes and wanes. The severity will rise and fall depending on your activity, if you're ill or not, depending on the weather outside. How many of you experience changes in your pain because a cold front just blew in, right? Very common. And so by taking the same exact dose every single day, you're really not doing yourself any favors. And I've seen physicians actually fire patients for this reason, because it looks like misuse. If a patient comes in, let's say for a random pill count, and they have more pills than, let's say, they were supposed to, right? It looks like maybe they're not taking the medication as prescribed, when in reality, that patient's just saving those pills for a rainy day. A lot of patients will self-dynamic dose, right? And so that's not, in my opinion, a reason to fire a patient, especially if they're being transparent about their use. We don't want patients to take medication if they don't need it. I think that's genuinely accepted across the board. So dynamic dosing basically reflects the humanity of our existence and doses us accordingly to that. It's kind of like a sliding scale for insulin, right? If your sugar is 300, you might need a little more insulin. If your sugar is only 100, well, maybe we can skip a dose and see how it is at the next meal. So that is what I refer to as dynamic dosing. And you can do it on a micro scale or a macro scale, from day to day, week to week, depending on your activity level, right? Let's say, you have 120 tablets per month, let's say, for example, and you have like a week off and you're not really doing much. Okay, well, maybe instead of taking 4 a day, you can get away with taking 3 or even 2, right? But then let's say, your brother or your sister is having a wedding out of state. Now you got to travel and stand upright for 4 hours straight. You know already that your pain is going to be much worse. So you can plan for that ahead of time and say, hey, I don't think 3 pills is going to cut it. I may need 4 or 5 during that time period. The key to all of this is to make sure that your doctor is in the know, so that in case you do get called in for a random pill count or something's not quite right, or you feel like you should take the medication that's not exactly how it is prescribed, it's always good to touch base with your doctor to make sure those changes are okay. But yes, dynamic dosing is a huge tool that we can use, even on the macro scale. A lot of times pain is worse during the winter. The weather's cold, the wind is harsh, and your joints just get stiff and that fibromyalgia kicks in and everything just seems worse. Very common. We will up that dose just a bit for a few months, with the plan and the intention to come back down again in the spring and the summertime. And patients find that to be very effective. What that does is, again, we may have increases, we may have decreases, but over time the average stays the same, and we're not increasing our dose over time. One final thing I'd like to point out here also is the acknowledgement of tolerance. We know that tolerance is a thing. You tend to get used to medication and you feel like you need more to get the same effect. One particular blood test that I like to test for my patients is testosterone. If you are on long-term opioid therapy and you find that maybe your energy is just not quite as strong as it once was, perhaps your mood is more labile, or you're not as, let's say, charged or driven as you once were. The reason for that could be low testosterone. We know that long-term opioid therapy will cause your testosterone to plummet. And so actually the funny part to this whole thing is that your opioid receptors rely on testosterone to function. So if you don't have testosterone or enough testosterone in your body, those opioid medications you're taking may not be as effective as they could be. And so again, unless you're thinking about this and testing for that, all it can look like is worsening pain or increasing tolerance, and that can result in inappropriate dose increases, changes of your medication, or even dose increases because your doctor may suspect that you could have something else going on, like an addiction. So we want to make sure that our testosterone levels are well within normal range, and you may need to have supplementation for that. You'd be surprised. Just by maintaining a current opioid dose, if your pain is going up and your testosterone is low, we can replace your testosterone, and that will cause your pain to improve. And we didn't change anything with regard to your medication. So these are the three big things that I like to do. Get that pharmacogenetic testing, because that's going to tell you everything that you need to do. Make sure that you are dynamically dosing your medication. Don't forget about opioid rotation. And always make sure that testosterone is within normal range. I guess that's 4 things. Maybe 3 if you include all the labs into one plan. So labs, opioid rotation, dynamic dosing. That is how I manage patients safely and effectively long-term on opioid therapy. Thank you for joining us. If you find this information to be helpful, do leave a like below, leave a comment if you have any questions, and we'll keep this content coming. Have a great day.